As a few reminder for our meeting today, if you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their device via Google Meet. For DUR board member, please preserve the question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendee that are not member of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you and welcome to our June DUR meeting. And I will leave it to Dr. Cannon.
Thanks, Noon. Good morning, everybody. It's a gorgeous morning. Little rain cleaned out the air. So thank you for that. I'm excited. Anyway, wanted to take just a minute at the beginning. I think in today's society where it tends to be more and more about me and more about our Instagram and Facebook, we sometimes fail to recognize those around us that quietly go about their work. And, with that, I'd really like to recognize the team at the Department of Health and all their energy and efforts and everything that goes in to running this pharmacy benefit for the Medicaid recipients in our state. And, they don't ask for recognition, but they definitely deserve it. So hats off to you guys. With that, everyone should have a copy of the minutes. Are there any questions from the board members on the minutes? Not hearing any. Do we have a motion to approve?
Move approval.
Thanks, Dr. Weinstein. Do we have a second?
Second. This is Dr. Turner.
Thanks, Dr. Turner. All right. All in favor?
Aye.
Aye.
Any opposed? Great. Everybody's just waking up. Okay. Noon. Those are approved. Do we have any housekeeping?
Yes, we do have a few housekeeping items. Lisa, if you want to go first.
Yeah, thanks, Noon, and thank you, Dr. Cannon, for your kind words. We appreciate the gratitude, although we don't expect it, but thank you. Yeah, we do have a couple of things we wanted to make sure that there's awareness of. It is June, so we are working on the DUR report annual submission to CMS. It's a new process this year, and so the ACOs have already submitted their portion for review, and we are working on next steps to make sure that everything is correct and appropriate and that we can complete the submission within the next week or so to meet the deadlines. Also, just wanted to mention that Jen Strohecker will be presenting next week on a legislative report that is reviewing the dispense as written override that we have in place on psychotropic medications. And subsequent to that review presentation that she will be working through next week, there will be a meeting with the stakeholders. So just wanted to make sure that there's an awareness of those two items. And I think Noon had something she wanted to add as well.
Thanks, Lisa. So last thing is an update on gender dysphoria bill that was signed into law on January 28th of this year. It was the SB Bill 16 that was signed to enact the provision regarding the transgender care treatment in minor patient who is under 18 years of age. The law does require certain change to be put into play by July 1st of this year. So by July 1st of this year, we will update and publish the hormone therapy for gender dysphoria to reflect those change and requirement. And some of the changes that coming is including the provider who's provide a hormone treatment for minors need to have the history for treating gender dysphoria with that minor for at least 6 months before submitting or providing any hormone therapy, and requiring the minor patient to have the mental health evaluation to be done by a separate mental health professional that is different from the provider who providing the hormone treatment as well. And have submit any documentation that the provider has talked to the minor patient about any side effect, risk, and benefit of using the hormone treatment for gender dysphoria, obtaining consent, and any others involving into the gender dysphoria care. So provider and patient and family can also find our requirement to on our website starting July 1st of 2023. And that is all of the housekeeping item that we have. Dr. Cannon.
Great. Thank you, guys. We appreciate that. So let's keep us rolling here. Let's turn it over to the University of Utah for their review of teplizumab.
All right, thank you. I'll be presenting on that today, and hopefully my screen share will work. It didn't work last time. Let me just pull up the slides. All right, that should be working. Let me know if you can't see the slides. So, hi everyone. Today I will present on teplizumab, a first-in-class monoclonal antibody and FDA-designated breakthrough therapy indicated to delay the onset of type 1 diabetes. Please refer to the full report for details. Type 1 diabetes, abbreviated in this presentation T1D, is typically caused by immune-mediated destruction of the insulin-producing pancreatic beta cells. It is a heterogeneous disorder with the peak age of onset occurring between ages 10 to 14 years. However, onset may occur at any age. For most patients, the disorder isn't recognized or diagnosed until the patient presents with hyperglycemia symptoms. An estimated 1/3 of children diagnosed initially present with diabetic ketoacidosis, a potentially life-threatening condition. Once diagnosed, chronic insulin treatment is required lifelong. Type 1 diabetes is associated with significant psychosocial distress due to medication administration burdens, complexities involved with controlling glycemia, life-threatening short-term complications such as severe hypoglycemia, and long-term complications including microvascular and macrovascular disease. In 2015, 3 U.S. organizations published a classification system for the stages of type 1 diabetes progression. This system recognizes a type 1 diabetes continuum, including predictable stages prior to developing hyperglycemia or meeting criteria for clinical type 1 diabetes. At-risk individuals classified as pre-stage 1 are those with genetic risk factors for type 1 diabetes. People with a family history are at increased risk for type 1 diabetes compared to the general population, but approximately 85% of people diagnosed with type 1 diabetes do not have a relative with the condition. This table shows the clinical criteria for the 3 stages of type 1 diabetes. Stages 1 and 2 include patients with seropositivity for 2 or more diabetes-related autoantibodies. Stage 2 includes patients with 2+ autoantibodies and detectable dysglycemia. However, the dysglycemia in stage 2 does not yet meet criteria for hyperglycemia. At stage 2, patients are usually not symptomatic. At stage 3, which I'll also refer to as clinical type 1 diabetes, patients have hyperglycemia and usually are symptomatic. A general consensus is that nearly 100% of people meeting criteria for stage 1 type 1 diabetes will eventually reach stage 3. However, the rate of progression through the stages is variable and may occur over months or decades. Once stage 2 is detected, the 5-year risk of stage 3 type 1 diabetes is approximately 75%. So this is where teplizumab fits in. Teplizumab is FDA indicated for people with stage 2 type 1 diabetes to delay progression to stage 3. A phase 3 trial for teplizumab among patients recently diagnosed with stage 3 type 1 diabetes is ongoing, with results expected by mid-2023. However, teplizumab is not yet approved for this indication. Teplizumab is the first agent indicated to delay the onset of stage 3 type 1 diabetes among people ages 8 or older with stage 2 type 1 diabetes. It is a humanized monoclonal antibody targeting the cluster of differentiation 3, an antigen on T cells. Teplizumab's mechanism of action is not fully understood, but it's proposed to modulate the immune system, temporarily correcting overactive T cells that target pancreatic islet cells. Teplizumab is delivered as a one-time 14-day regimen. Doses are given once daily by IV infusion in the outpatient setting. The total dose is determined by body surface area. To mitigate potential adverse effects such as cytokine release syndrome, the dose is gradually up-titrated over the first 4 days of the regimen. Pre-medication with an antipyretic, antihistamine, and/or antiemetic for a minimum of the first 5 days of treatment is recommended. To initiate teplizumab, prescribers should confirm a diagnosis of stage 2 type 1 diabetes based on positivity for 2 or more diabetes-related autoantibodies and dysglycemia without overt hyperglycemia. It's recommended to confirm dysglycemia with an oral glucose tolerance test, or OGTT, but another glycemic test can be used if OGTT is not available. The patient's history should not suggest type 2 diabetes. Before starting teplizumab, it's recommended to check the patient's complete blood count and liver function test for the absence of significant abnormalities. Additionally, patients should not have an active, serious, or chronic infection, including acute Epstein-Barr virus or cytomegalovirus, when starting teplizumab. Patients should receive age-appropriate vaccinations before receiving teplizumab. The pivotal trial for teplizumab approval was TN10, a randomized double-blind phase 2 placebo-controlled trial comparing daily teplizumab infusions to daily saline infusions for 14 days. There were 78 participants in the trial, including 44 in the teplizumab arm. Patients were between ages 8 and 49 with a relative with clinical type 1 diabetes and had stage 2 type 1 diabetes based on seropositivity for 2 or more of the autoantibodies and elevated blood glucose without overt hyperglycemia per the OGTT test. At a median follow-up of 745 days, teplizumab significantly delayed the onset of stage 3 type 1 diabetes by about 24 months compared to placebo. And at 923 days of follow-up, the last published follow-up that I've seen, time to diagnosis of clinical type 1 diabetes was delayed by a median of 32 months, approximately. In the TN10 trial, common adverse events among people who received teplizumab included transient lymphopenia, leukopenia, rash, and headache. Labeled warnings and precautions for the use of teplizumab include the risk of cytokine release syndrome, serious infections, lymphopenia, hypersensitivity reactions, and the recommendation that patients receive age-appropriate vaccinations before receiving teplizumab. White blood cell counts and liver function tests should be monitored during treatment. Anti-teplizumab antibodies were detected among more than half of the TN10 trial participants following treatment. Whether this impacts efficacy is unknown. There is limited information about risks of teplizumab during pregnancy, but theoretically, teplizumab may cause fetal immunosuppression, and use during pregnancy is not recommended. U.S. guidelines do not provide treatment recommendations for stage 1 or 2 type 1 diabetes yet, and thus do not yet give recommendations about teplizumab. The American Diabetes Association, or ADA, does recommend counseling individuals with diabetes-related autoantibodies about the risk of developing type 1 diabetes, including signs and symptoms to watch for. The ADA also provided recommendations about screening people for type 1 diabetes autoantibodies. They recommended optionally screening relatives of people with type 1 diabetes for the 4 autoantibodies listed here as part of regular clinical care, and reserving screening for the general population without a relative with type 1 diabetes to the clinical trial setting. In summary, people with stage 2 type 1 diabetes characterized by seropositivity for 2 or more diabetes-associated autoantibodies and dysglycemia without overt hyperglycemia are expected to progress to stage 3 type 1 diabetes, regardless of family history. Teplizumab is the first FDA-approved therapy to delay stage 3 clinical type 1 diabetes. The indication and evidence for use of teplizumab is among people with stage 2 type 1 diabetes. Ongoing trials are evaluating teplizumab for use in people with stage 3. In a small pivotal phase 2 trial, teplizumab delayed onset of stage 2 type 1 diabetes by at least 24 months compared to placebo. According to some experts, delaying onset of type 1 diabetes by at least 2 years may be clinically meaningful, as it delays the time to requiring insulin and may theoretically delay or lower the risk for diabetes-related complications. Current U.S. guidelines do not yet address teplizumab. Guidelines recommend education and monitoring for people diagnosed with stage 1 or stage 2 type 1 diabetes. This slide and the next slide summarize considerations for potential prior authorization criteria for teplizumab. You can also refer to page 24 of the report for details. If a drug-specific PA criteria is desired, the DUR board may consider recommending provider attestation to teplizumab being used according to its FDA-approved indication, which is for people at least 8 years old with a diagnosis of stage 2 type 1 diabetes. Consider also requiring that providers attest to completion of recommended laboratory monitoring and normal parameters before starting teplizumab. If desired, PA criteria could also require attestation or documentation the patient does not have abnormal hematologic or liver function abnormalities or active infection as listed at the bottom of this slide. Or alternatively, this information could be considered for educational information on the PA form. Additionally, teplizumab should be restricted to a single course of 14 infusions total. Other considerations include listing educational safety information on the PA form, such as administering urgently needed age-appropriate vaccinations before teplizumab therapy, and if desired, requiring that teplizumab be prescribed by or in consultation with an endocrinologist. Thank you. That's the end of the presentation for today.
All right. Does anyone on the board have any questions for Lauren? All right. Why don't we move on? We have public comment. John Aldridge, are you on the call? I guess
Yeah.
most of you are in the room, but probably not.
Morning.
Good morning.
I don't have much to add there. I think I just need to get Lauren's address at the U and send her a thank you card because she completely crushed that presentation on teplizumab and TZIELD. So I think it was fantastic, and she hit all of the highlights and points. One thing I will just quickly throw in there, which I think she did touch on, was the fact that although this is a highly genetic disease, 90% of individuals that are diagnosed with diabetes, type 1 diabetes, do not have a family history of type 1 diabetes. And the rate of progression once an individual does have 2 or more autoantibodies is going to be similar amongst those, or the same amongst those with family history or not.
Okay. Thank you. Does the committee have any questions for John? Can I ask one question in terms of screening? I mean, is there a standard screening that's recommended? This, most of these patients are probably seeing primary care. Not something they would maybe be looking for or thinking about. What's the direction that care is going in terms of screening?
Yeah, at this point, I mean, it's difficult, and that's something that's being continuously worked on. First degree relatives are kind of the primary point of screening. There are some programs out there, like the program here in Colorado, where I am based, called the Ask Research Program, where centers, endocrinology centers like the Barbara Davis Center, are working with local pediatric offices to do general population screening. So it's free for anybody to go in, but the screening process is something that is that they're working on at this point, because to Lauren's point earlier, this was really recognized in 2015. Those with 2 or more autoantibodies as type 1 diabetes by ADA, Endo, as well as the JDRF. So, it's been a relatively short time span since that was really recognized as type 1 diabetes, having those autoantibodies.
All right, great, thank you. Anything else from the committee? All
I have a
right.
quick question, Eric, if I can.
Yeah, you bet, Chloe.
How are these patients being infused? Is it in the hospital, doctor's office? How are they getting weekend infusions? I'm just curious, 14 days straight, what the service level is there.
Yeah, that's a complicated answer, and a lot of it comes back to what the payer is going to require. Many of the clinicians, being that this is being used in pediatric patients, do feel more comfortable having those patients infused in a clinical setting, for sure, versus doing at-home infusion. But really, at this point, they're working with payers to kind of determine where these individuals need to be infused. There are some, I see the question there. There are some infusion centers that I know that have engaged patients or have been used as well out there. So.
Dr. Siegfried have a question as well.
Yes, I wanted to know whether there were any, in the subgroup analysis, any autoantibodies that predicted either a poor outcome or, say, a better outcome compared to others. I think I had read somewhere that certain autoantibodies seem to potentially predict, differential outcomes in terms of either length or severity of type 1 diabetes. I was just curious what your study showed on that.
Yeah, I would have to look up the exact forest plot, like subgroup analysis there, but the N was, to be really transparent, the N was so small in that subgroup analysis, as well as the fact that it wasn't taking into account multiple factors, to where it was just, there may not be much validity to the differences in those different autoantibodies. Zinc transporter 8 might have had a slightly less, in favor of teplizumab outcome, but it was just the ends were so small that honestly, I don't think it was relevant.
And Joe, you have a question as well?
Yes, quickly, John, in the dossier that you prepared, Lauren mentions the clinical trials among patients with a new onset stage 3 type 1 diabetes. Do you have any additional information on that particular work, and are there other yet unpublished research that you can share with us on the use of teplizumab in other patient populations?
Yeah, so the study that she was talking about is called the PROTECT study, and the top line data from that PROTECT study should be coming out hopefully in the next 6 weeks. The PROTECT study was conducted in individuals that were diagnosed within the last 6 weeks. They had to start drug within the last 6 weeks after diagnosis. They were given 2 doses of drugs, so within that time period, and then up to a year after, with the primary endpoint being C-peptide preservation. So more to come on that in those newly diagnosed patients. As for other publications, yeah, there's many studies that have been done over the past 2 decades with teplizumab. So that would be something that I can definitely get over if there's, interest in a particular study, but numerous studies done over the past 2 decades.
All right, Dr. Smith.
Sorry. So what is the largest trial that we have available with published data right now? How many subjects?
Well, based off of this stage 2 patient population, the 76 that were alluded to. However, for the BLA approval of this medication, they pulled the data from previous studies for safety factor, and they looked at 791 patients, essentially, that received teplizumab.
Thanks.
Okay. Thank you, John. We appreciate you answering questions and being here today. So
Thank
thank you, Lauren. Noon, do we have a proposed prior authorization criteria for us to discuss?
Yes, Dr. Moreno will present the TZL prior authorization right now.
Okay.
All right, thank you, Noon. Hi, everyone. This is the T-Shield teplizumab prior authorization criteria. And as always, it is based on prescribing information and clinical trial information.
Luis, we don't see the PA yet.
Oh, okay.
I just stop sharing and then share again. Sometimes that helps.
Good idea. I'm trying to share a window here. Is it better to share a tab?
We can see
it
that now.
Oh, excellent. Very good. So as you can see here, I wanted to point out, we asked for the body surface area or weight and height in order to verify dosing. And then to the criteria, it says all of the following criteria must be met. Medication being prescribed by or in consultation with an endocrinologist. And then the patient is 8 to 45 years of age and does not have stage 3 type 1 diabetes or type 2 diabetes. Is not pregnant. And then we have a confirmed diagnosis of stage 2 type 1 diabetes by documenting the presence of 2 or more pancreatic isolated autoantibodies. And then this is the piece that has to do with relative that has type 1 diabetes, meaning the following. First degree relative must be between 8 to 45 years old. Second degree relative must be between 8 to 20 years old. The patient is pre-symptomatic with no overt symptoms of hyperglycemia, and then documented impaired glycemic response with the 2-hour postprandial glucose between 140 and 199 with an OGTT. Or if the OGTT is not available, then an alternate method for diagnosing dysglycemia without overt hypoglycemia may be appropriate, such as a fasting plasma glucose or an A1C. In the last 3 months, patient has not been previously treated with Tzield, and then the treating provider will attest to labs per the teplizumab prescribing information. And the treating provider will administer all age-appropriate vaccinations prior to or after treatment as recommended by the prescribing information. And the treating provider attests to counseling the patient regarding the need to complete 14 consecutive days of infusions without missing a dose. And then after the criteria, we have the initial authorization. So it must be administered IV once daily for 14 consecutive days according to the recommended dose and administration schedule in the prescribing information. And then for reauthorization, it's not applicable as this is a once in a lifetime dose. And that is it. Dr. Weinstein? Oh, go ahead again, sorry. Yeah.
I mean, Dr. Winston have a comment.
Thank you. Just a couple of things. So we're looking at, I'm looking at the confirmed diagnosis of stage 2. So the fourth bullet down, would that be all of the following sub-bullets have to be included? Just for my understanding, is that would be the way that reads?
Yes.
I don't remember the criteria. Okay. And then coming down, there's, I think it's one of the last criteria would say the treating provider would administer all the vaccines, or could we say will document all age-appropriate vaccinations have been administered? Because it's possible, you know, if the endocrinologist is administering this drug therapy, maybe the vaccinations have been given by the pediatrician. So I might just adjust that wording. That's maybe, you know, how that is being done in the clinical care, just to make sure they're done, but not necessarily administering them themselves. And if that wording's acceptable. Then I had one question. If it's relevant, I'm not sure. Again, this isn't my area, but we have this big stage 3 trial about to come out in 6 weeks. And I don't know if that, if there are data to, you know, emerge from that trial that would affect this or not. Or if we could go ahead with this and then look to see what comes out from that trial, or if we should hold off on this until that comes out because it's significant. I just don't know, and I'm sure others on the call are more informed about that than I am. So that's a question. So my only proposal on this is to maybe adjust the wording of that second to last square bullet. Thank you.
All right, Catherine, you had a comment.
Yeah, I just wanted to echo Dr. Weinstein's comment about the clinical trial that should be coming out soon. I guess I have some concerns that this is based on really relatively very few patients being studied with respect to the risk of lymphopenia. And I would just be really interested to see what those new trial results would show.
Thank you. No, great point. Dr. Siegfried?
Yes, back up under the bullet point, confirmed diagnosis. I noticed you added in that member has to have a relative with type 1 diabetes. what if you have someone that was adopted or does not have a family history of diabetes? It's basically you're excluding those individuals who meet all the other criteria from receiving this medication because either they don't know their family history or they don't have a family history of type 1 diabetes. I'm not an endocrinologist either, but I don't want to be, so narrow in our prior authorization requests that we may exclude people who actually might benefit from this medication. Thank you.
I think this relates to who should be screened, because in the general population, you don't know who, at this point, patients are asymptomatic. We don't know who's at risk. And you don't screen every kid that walks into the office for these markers. And so this is a way to identify potential candidates, because it is such a big unknown.
Sorry, I'll jump in. So then this goes back to my initial question, if these are all-inclusive criteria or these are or criteria. In other words, all of these would have to be documented as inclusive to meet the criteria for the PA, or they are any one of these, or two or more, or again, if we're saying that the patient might not have a family history, they might still be included if the others are met. And I think that's Dr. Siegfried's point. Thank you.
My understanding was that they were and, with the exception of the first degree versus second degree relatives, where that would be an or. Louise, correct me if I'm wrong. Louise or Noon.
Yes, that's correct, Brian.
I agree with Dr. Siegfried. This is Dr. Turner. I understand that you would routinely be screening children without a family history. However, if a child did present with dysglycemia that was caught in some routine screening and further investigation turned up autoantibodies, I would think that child meeting those criteria should be eligible for treatment.
Hi, this is Shannon from Healthy U. We also looked at TZIELD and looked at the inclusion and exclusion criteria. And it was an end for us, proposed as an end, because if a patient just had a family history without having the dysglycemia and the autoantibodies, then it wouldn't make sense to start TZIELD. So I think the most important thing is the autoantibodies and the dysglycemia. And then as far as the family relative, I think that could be debated.
Let me just kind of take a poll here from the committee members. Then Neil will jump to you. How many would be more comfortable waiting to finalize this until after we've got trial data here in 3 weeks? Got a hand from Catherine.
Yes, from Dr. Turner.
Dr. Catalano.
Dr. Siegfried.
Okay. I think that just pretty much covers the whole study. So at least it's unanimous, or it's strongly in the majority. Let's say that, since I don't have a formal count here. Okay, Neil, you had a comment, and then Colby will get to you.
Well, I was just reading this, and the bullet point: member has a relative with type 1 diabetes that meets the following. When I initially first read that, made me think that the relative needed to meet the following. And it just kind of confused me a little bit. If the relative, brother, sister, could we just put in that clause, patient must be between 8 and 45 years. So it kind of matches what the exclusion or inclusion criteria was. And if the second degree relative and patient must be between 8 and 20, or person or member, however it was worded above. But when I first read that, member has a relative with type 1 diabetes that meets the following, I thought, wait a minute, why are we worried about the relative here? Maybe I'm splitting hairs here, but I was just trying to call that out, that it was more definitely related to the patient. Am I off base this morning, Eric? Or team?
Sorry.
I agree with you. That was our intention when we looked at it, is the patient was within that age group.
Maybe it's early and I'm just reading it wrong or missing it, but it just kind of, I just think the clarity would be helpful on that. Cool. Thank you.
Definitely.
So it could be worded as if that, the patient has appropriate family history based on the following. And that could be an and, or, it could be an or. Somebody else had a hand up.
That was me. I was going to echo Neil's interpretation of that the way that's worded, the relative has a relative. And I don't think that was the intention.
Right.
Yeah. So the patient has a relative is how, or the candidate for therapy has a relative is how that would read. And so I think on this document as a proposed criteria, for prior authorization, we have a couple of wording changes that we would want to clarify. But I think, in that this particularly needs some expert consideration as to how we want to step that as a consideration for the criteria. But the other wording that I suggested was really just to clarify how things are in clinical practice. But I think more broadly, I think we could have this document revised, and then pending the receipt of data from the other trial, which is shortly to come out, we could come back and revisit if there are any other major considerations to this, because we have the benefit of that trial to come shortly. If it was going to be 6 or 12 months, I think we might not do that. But given the short turnaround in the other trial, we might be able to work on this in the interim, and then have a quick review when that other study is completed and those data are available.
Right. I actually really like that recommendation. Lauren?
Yes, thanks. I just wanted to clarify with the team regarding the duration of approval. I think it's on the second page of the PA criteria. The initial authorization. I couldn't tell from how it's worded. I just wanted to clarify. Does that mean the authorization will be for 14 days and wouldn't necessarily allow for like an interruption in the 14 days of therapy? Or would it allow for a brief interruption and a restarting of therapy that might extend beyond 14 days?
I guess I'd turn that around and ask you, what's the impact of interruption?
Well, according to the prescribing information, there might be allowances for an interruption if they have like cytokine release syndrome. They might pause therapy and allow recovery and then restart therapy. So there's definitely some areas where there could be a temporary interruption of therapy.
Is there any data around how long of an interruption has been studied and what impact that would have on the efficacy of the treatment?
I'm not aware of that data. I don't know if the representative prevention from Prevention Bio may be aware of any data.
Sorry, I just kind of heard that. Yeah, there's really not data, and the PI itself is pretty vague, lending to clinician decision on restarting therapy.
John, were there any patients in the clinical trials that had a treatment interruption? And if so, what were their outcomes?
In the TN10, there was not. I would have to go back and look at previous trials.
So what would you advise we do if a patient misses dose 7? Should they continue therapy? Should they not continue therapy?
Well, per the label, it would be, again, the clinician discretion. However, we're running into, to someone's point earlier, with some of the, the 14-day continuous infusion here. Let me back that up. I guess one thing to point out is that the half-life of the drug itself is 4 days. So being that drug still is in system, some providers are comfortable with, depending on the circumstance, restarting dose after a couple days of taking time off.
Is this data we anticipate might be coming out in a few weeks? Will there be any mention of this in the new data to be released?
I don't know, in being that it's going to be in a different indication as well. Yeah, I don't know.
All right.
Dr. Cannon, I have a quick question.
You bet. Yeah.
On the data we're waiting for in 3 weeks and stuff, there probably won't be a label change to this product for quite a while or a while. What difference will this make in our decision or the redesign of this PA? Just throwing that out to the team, based if we're staying on label or considering the other, the data. It may take a little longer for a label to be changed. So will it change our course with this prior authorization? Thoughts?
I guess I could see it making some changes to the prior authorization in terms of safety. And I think it just gives us more clear guidance in terms of, are we comfortable this is the direction to go? I think, and Noon or Brian or Joe or Lisa, somebody will correct me, but in the meantime, if a request comes in, it is still reviewed for medical necessity, which I would assume would be grounded to some degree in the criteria that's already here in front of us. Am I safe in that assumption? So we're not denying access. By waiting, we don't deny access to anyone over the next 4 weeks.
So
But what we do
right
is, go ahead, Noon.
Oh, sorry. So right now, this PA is not published, and we don't have any edit implement on this PA since it hasn't passed through the DUR board. And so it will still be an access to this medication without any restriction at the moment until the PA posted and published.
Okay. Thank you.
Dr. Weinstein.
I just wanted to go back to the authorization period and make sure I understand the difference between the authorization period and treatment. So if the practicalities being an authorization period means the treatment is completed within that period. So practically speaking, Maybe they're going to an infusion center. They don't get there on a Sunday or something like that, or the patient has a reaction. Treatment has to be interrupted for a day or two. Would there be an authorization period that had a little bit longer time frame to allow for some logistic and or clinical interruptions? And if you put and then it's also my question, if you put a date range down for an authorization and that starts on a certain date, and then the patient doesn't get in and start the infusion on that date, does the authorization expire before they get treatment finished? So there's logistical questions that I have about how that authorization works. But then it's just, again, if in clinical reality, the patient might have treatment interrupted for a day or two, or maybe even 3 or 4, should we put an authorization out for, maybe 21 days, or is that reasonable?
Yes, Dr. Weinstein. So we do encounter that in not just this medication, but others as well, where the logistic is miss and match with our PA criteria, BA authorization term, and the provider can reach out to us and we will adjust the day of approval and the end day of the PA to accommodate any change in their infusion schedule. But this doesn't answer, the main question is how long is the interruption for this treatment? Is that requiring the provider to restart or to stop the therapy? This is still the question that we have for this therapy as well.
Can I ask a question, please?
Yes, go ahead.
Okay, as a public member, what I can't understand is what is the emergency or, to push that through and not wait for the study? I still don't have that clear understanding. In other words, it's all right to wait, for few weeks and then incorporate the results of the study. And then that way we would have some backup, How many patients would be benefited if we rush it through today?
Well, Kumar, I think what we've heard is we don't have the door's not being nobody's breaking down the door right now. So I think, if I can make a recommendation and then we'll let you guys modify it into a motion. I think we've got a couple areas of the criteria that as a committee would probably like to see reworked. One would be under the diagnostic criteria about first and second degree relatives.
Right.
If that can be cleaned up so that it's more clear and kind of in line with what the committee's thinking. I think there also needs to be some process there for adopted children or people that just literally don't know that family history. I've got 2 daughters that wouldn't have any clue to their family history. So I think that's important. The second being this 14 consecutive days, you heard John say with a half-life of 4 days, some physicians are okay with a couple-day interruption. Does that mean you administer a dose and then wait 2, 3, 4 days and then administer another one? Is there a window of 20 days, 21, 24, 25 days that we say it has to be administered within? And it's probably 20 or 21 at least. Dr. Weinstein's pointing out that documentation on the vaccinations, not necessarily that the physician attests they've given the vaccinations, but that they're complete. I think that's important. The second being this 14 consecutive days, you know, the 14 consecutive days, some physicians are okay with a couple day interruption. Does that mean you administer a dose and then wait 2, 3, 4 days and then administer another one? Is there a window of 20 days, 21, 24, 25 days that we say it has to be administered within? And it's probably 20 or 21 at least. Dr. Weinstein's pointing out that documentation on the vaccinations, not necessarily that the physician attests they've given the vaccinations, but they're complete. does that resonate with the committee? I'm seeing some nodding heads from Joe. The only head that matters.
Yes, sir.
All right. How about a motion?
Could summarize that into a motion for you, Eric, which is that we make these revisions to the proposed PA criteria for this agent and bring it back to the committee with any relevant information from the study that's pending to consider for adoption as soon as possible.
Right.
I'll second that.
Okay, we have a motion and a second. Kumar's already in favor. Who else? Everybody okay? Any opposed?
Aye.
Hearing no opposed, we will assume the vote is unanimous. And noon, I think that concludes our business of the day,
Yes.
unless there is something else.
We don't have anything else for today. Thank you very much for a very robust discussion.
All right. Well, and thank you. Committee was incredibly efficient today on not an easy subject. So thank you. Do we have a motion to adjourn? Kumar's motioned and seconded. So with that, all in favor?
Have a good Fourth.
All right. We are adjourned. We will see everybody in another month. Thanks, guys.
Thank
Thank you.
Have a good day.
Bye.
You too.